Please start the session, sir. We are live.
Yes. I think it's a great pleasure to invite Professor Vishal Sharma, who is a wonderful gastroenterologist currently working in PGI, the prestigious institute. And there is a peculiar problem, aspirin, whether it is the foe or friend to a gastroenterologist. You know, there is a lot of data which talks about, aspirin as a preventive one, and aspirin, both bleeding and malignancy, and also aspirin as a precipitator of ulceration and bleeding. I think these two addresses will be, very nicely addressed by Professor Vishal, and I welcome him. Sir, without wasting much time, could you please start your slide sharing and do.
I hope the slides are visible, sir.
Yeah, it's visible, and just go ahead. I mean,
thank you so much, sir. Thank you so much for the kind words of introduction, and I agree with Dr. Sethu that this is a drug which is a wonder drug in some of the situations, but also has its troubles which are associated with it. So the topic which I am supposed to talk about in the next 30 or 40 minutes is about an approach to gastrointestinal manifestations of aspirin and antiplatelets. So what I'll do is that I'll briefly talk about these drugs, then the mechanism of gastrointestinal action. We'll have a word about the gastrointestinal effects of their use and what is the frequency of these particular adverse effects. And then what are the risk factors which could predispose to such things. Eventually, we'll talk about the monitoring and diagnosis of the GI adverse effects, and then what are the strategies which we could use to minimize the gastrointestinal risks. And then that of course will encompass a discussion about the optimal duration and of the therapy, about concomitant use of prostaglandin analogs or PPI, role of H. pylori eradication, and eventually we'll very briefly cover what the guidelines say. So we first come to the drugs. So we know that anti-thrombotics are a broad group of drugs. We have the antiplatelets, the anticoagulants, and the fibrinolytic agents. So today we are going to talk only about the antiplatelet drugs. We know that the thrombus is basically multiple platelets which are aggregated because of the fibrin. So antiplatelet drugs inhibit the platelet activation or the aggregation. And of course, the other two types have action at different sites, but they are not the focus today. Now, if we want to understand the antiplatelet action, we must understand how this particular thing happens. So when there is an injury to the endothelium, there is release of the collagen or exposure of the collagen and release of the von Willebrand factor, which attracts the platelets through the GP1B and the 6 receptors. Now, this is platelet adhesion. Once these platelets are adherent to this particular site of injury, they recruit other platelets, and this is mediated by the adenosine phosphate, which binds to the P2Y12 receptors. And then, of course, there is the aggregation where the platelets join up, and this is mediated by the attachment of fibrinogen to the GP2B3A receptors. And of course, then there are other mechanisms like the thromboxane A2, which activates the platelets, and the thrombin receptor. So there are multiple sites where antiplatelets could act. And if you want to understand, then of course, there could be inhibitors of the P2Y12, which are clopidogrel, prasugrel, and ticlopidine. And then there are certain reversible agents like cangrelor and ticagrelor. So these, this is the site of action of these agents. Then there could be 2B3A blockers. Most of them are intravenous, the eptiximab, tirofiban, and eptifibatide. And of course, then there are drugs which increase the cyclic AMP levels, and that could be dipyridinol. And of course, we have our aspirin, which acts at the thromboexane level. So aspirin is, of course, arguably the most prescribed drug, but the benefits are known from the ages. And if we see Hippocrates was also aware of the effect of willow bark, which could relieve pain and fever. But the synthesis of this particular agent was probably done by Felix Hoffmann in 1887. And if you see, after that, this drug has really gone places. Of course, there is a controversy that somebody else, Arthur Ischemic, was the inventor of the process, but usually it is Felix Hoffmann who's credited with this discovery. Now, what are the mechanism of gastrointestinal action of these drugs? So we understand that aspirin is not just an antiplatelet, but also an antipyretic. And this is basically dependent upon the dose. At a dose which is low, that is less than 325 milligrams in a day, the action is primarily at the COX-1, and that is an antiplatelet action which is of use in cardiovascular and cerebrovascular diseases. On the contrary, the high dose, that is more than 325 milligrams per day, is an anti-inflammatory dose which inhibits both the COX enzymes and has an analgesic and an anti-rheumatic action. Now, the action could either be a local action directly at the level of the stomach, or it could be a systemic action after absorption of the drug or the metabolism into the active metabolites. So, if we talk about the local effects of the aspirin on the gastric mucosa, we know that there is a phospholipid bilayer, and because this drug is a weak acid like most of the NSAIDs, it tends to be in a non-ionized form and stays close to this membrane, disrupting this membrane. And eventually the mucous layer also, which has a protective role, is disrupted, and the drug leaks into the epithelium, where it becomes ionized, and there is a kind of an ion trapping, and it gets trapped into the epithelium, resulting in damage to the tight junctions and epithelial injury. Now, it also disrupts the mitochondrial phosphorylation function, and again, all of these mediate the local actions resulting in gastric injury. Now, these are the mechanisms I've already talked about: the disruption of phospholipids, cell membrane disruption, decoupling of the mitochondrial phosphorylation, the direct cytotoxicity of the salicylic acid, changes in NO synthase, in fact, increased nitric oxide production, and alteration in the local microcirculation. Now, coming to the systemic actions, if we see, then the membrane phospholipids are metabolized by phospholipase A2 into arachidonic acid, which can either go to the lipoxygenase pathway, resulting in leukotriene formation. More importantly, we have the COX-1 and the COX-2. Now, COX-1 is a housekeeping enzyme, which is usually present and has a role in formation of prostaglandins, which help in GI mucosal protection and avoid platelet aggregation. Now, the COX-2 is inducible and induces when there is an inflammatory setting, and usually it is not very active. So, low-dose NSAIDs act on the COX-1, and that is why they have an antiplatelet action, but also they disrupt the GI mucosal protection. On the contrary, the COXIBs have an action on have a COX-2 selective action, and therefore the GI toxicity is much less. But in certain situations when COXIBs are combined with the aspirin, then the GI protection is lost. The traditional NSAIDs act on both of these sites, the COX-1 and COX-2, and have both an analgesic and an anti-inflammatory function, and also have a GI toxicity. So the gastroscopic observations which suggested that aspirin could result in I would say, injury to the GI tract, that was first documented around 4 decades after the discovery of aspirin. And you see that 16 patients who had used aspirin, 13 had some positive findings. And you can see that there were hyperemia, there were petechiae, and mucosal hemorrhages. And these are the plates which are available from this Lancet paper, and you can see that some of them do show ulcers. Now, the next question is that whether thienopyridines also cause ulcers. So this was an interesting work where 36 healthy volunteers were randomized to receive clopidogrel or aspirin. And you can see that while the median value of the injury score, that is the modified Lanza score, were similar at the baseline, when the second gastroscopy was done after the use of these drugs, you can note that the scores increased in aspirin but not in clopidogrel. So clopidogrel per se may not cause GI ulcer or gastric ulcers, but then why does it increase the risk of bleeding? So we know that the repair of GI mucosal disruption involves the platelet function, the aggregation of platelets, which results in release of various factors and angiogenesis. Now, clopidogrel will act on this and impair the healing of the gastric erosions and ulcers. So, if you want to understand, this means that whatever may be the cause of the ulcer, the healing and the bleeding is likely to increase with the healing is likely not to happen if clopidogrel is being used, and the bleeding risk will increase. Now, coming to the gastrointestinal effects of the use of these drugs. So the effects are protean, and they could occur at any site. So in the esophagus, these drugs may cause piloesophagitis. They may predispose to pain in the epigastrium or the chest, or occurrence of reflux disease. We are more aware of the manifestations in the stomach, which may be erosions, petechiae, formation of ulcers. This may result eventually in bleeding or perforation, and the patients may have symptoms of dyspepsia and vomiting, apart from abdominal pain. Now, the other thing is the NSAID enteropathy, that is the involvement of the small bowel, and the findings similar to the stomach, like the erosions, ulcers may occur, and occasionally there may be formation of diaphragm-like strictures, which are short, few millimeter long only strictures, which can bleed also, may have associated ulcers, and can result in intestinal obstruction and abdominal pain. So again, the manifestations could be in the form of pain, intestinal obstruction, diarrhea, hypoproteinemia, obscure bleeding, and GI perforation. Now, the involvement of colon is less frequent, but again, the findings similar to the small bowel, which are known as the NSAID colopathy, may also be occurring with the use of aspirin or NSAIDs. Now, we must understand that there is a biological progression of GI damage, which happens with low dose aspirin. And in this very nice, I'd say, pyramid, it is shown that while prostaglandin inhibition is universal, the erosions are very frequent. There's a decline in numbers as you proceed from the ulcers to the symptomatic ulcers, to the patients who have complications, and an occasional patient may have mortality also because of the complications of ulcer disease like bleeding or perforation. Now, this was a very interesting survey. So there is a UGLA in France, which is a group of patients who can be actually contacted for health-related surveys. So 10,000 questionnaires which were sent to individuals of more than 50 regarding the use of aspirin. Of the 8,000 odd questionnaires which were eligible, 986 patients were on aspirin, and of them, around 15%, that is 150 patients, had upper GI symptoms. So, of patients who were more than 50 and were on aspirin, 15% have GI symptoms. And the most prominent of them are the reflux disease, more than 50%, and around 50% you have heartburn, acid regurgitation, you may have bloating, you may have belching, and aerophagia in a significant number of these patients. Now, the dyspepsia, as we said, is one of the frequent manifestations, but serious complications can occur in 1 to 2%, and the mortality from upper GI bleed could be to the tune of 5 to 10%. Now, let us compare the GI adverse effects of clopidogrel and aspirin, and this is data from the CAPRIE trial, where around 20,000 patients with recent MI, ischemic stroke, or peripheral arterial disease were randomized to either clopidogrel or aspirin, and you can see that GI bleeding, whether it was major, fatal, was more common in patients who were on aspirin, as was dyspepsia. But diarrhea was more common in patients who were on clopidogrel. Now, coming to prasugrel, this is data from the TRITON trial. 13,000 odd patients who were up for PCI. They were randomized to either a clopidogrel loading followed by a maintenance dose, or a prasugrel 60 milligram loading and 10 milligram maintenance dose. You can see that the major bleeding, life-threatening bleeding, non-fatal bleeding, and fatal bleeding were all higher in the prasugrel group. And here you can see that the patient of GI bleeding, the numbers were more in prasugrel group as the time progressed. And then after this, there was a meta-analysis which compared around 60,000 patients who had received one of these three antiplatelets, ticagrel or prasugrel or clopidogrel. And you can see that when the comparison was between either of the drugs versus clopidogrel, there was no real difference, but the risk of bleeding was more when prasugrel was compared to clopidogrel. And you can see here that the relative risk crossed the line of no effect, and the risk was more. So if we want to understand what is the risk of upper GI bleed with various agents and a combination of agents, you can see that with low dose aspirin, the risk is around, the relative risk is 3.6. When on the other hand, a non-steroidal anti-inflammatory drug is used, it is more. A combination further increases the risk. When it is a single antiplatelet like clopidogrel or ticlopidine, the risk is around the same as aspirin. But when you combine it with an NSAID, the relative risk increases many-fold. So the message is that while the risk of aspirin with other antiplatelets may be slightly more or similar, as you add an NSAID, the risk of the bleeding increases. So coming to the risk factors for GI adverse effects, why do we need to assess the risk factors? I think this is very important for us to understand. Not all the patients of those who take antiplatelets and present with GI bleeding have previous dyspepsia. So what I want to say is that a substantial number of patients who present with a serious complication, around 80% in one study, do not have antecedent dyspepsia. And therefore, it is important to stratify at the start which are the patients who are at the high risk of bleeding and adequately address these risk factors by various armamentarium. So what are the risk factors for GI bleed? Elderly, especially age of more than 75, presence of comorbidities like chronic kidney disease or diabetes mellitus, a past history of GI bleeding or an untreated peptic ulcer disease, Helicobacter pylori infection, smoking or alcohol intake, and use of higher doses of an agent. So maybe a 100 milligram dose or a 75 milligram dose versus a 325 milligram dose of aspirin, the risk is more with the higher dose. And of course, use of additional drugs like steroids, NSAIDs, and additional antiplatelets also increase the risk of GI bleeding. So this is data of GI complications with low dose aspirin. So in patients with who are less than 70 years, the events were just 7 per 1,000 person years, increased to 22 with the age of 70. If there is a past history of ulcer, the risk was 32 per 1,000 person years. If both of these, that is age more than 70 and a history of ulcer, it again increased. If there were three risk factors, like age, male gender, or NSAID intake, the risk was still high. The highest risk was in the patients who had previous ulcer bleeding. So we can see that as the risk factors add up, the risk of complications of bleeding increases. Now, this was a very interesting study where 187 patients who were on low dose aspirin, that is 75 to 325 milligrams each day, you can see that the point prevalence of ulcers at either of the site was 10% or around 11%. The erosions were in 63%. The incidence or new onset of ulcers was 7% and erosion 60%. Now, 20% only whether they had ulcers or did not have ulcers, had underlying dyspepsia. So dyspepsia is not a very good symptom to assess the underlying presence or absence of ulcer. And in fact, the presence of Helicobacter pylori increased the risk of development of duodenal ulcer, but not of gastric ulcer. So there is this erosion paradox, a very interesting paper again, where you can see that there were two groups. One was H. pylori positive, the other was H. pylori negative. And you can see that the erosions were more in the H. pylori negative group. And the median, the number of erosions which are present in stomach, or the median number of erosions which are present in stomach, were more in the Helicobacter pylori negative patients as compared to positive patients. So there is an ulcer erosion paradox, the ulcers being more in the patients who have H. pylori, especially the duodenal ulcers, but the erosions in the stomach are less. Now, coming to monitoring and the diagnosis. So, in the clinical history, I think it is important to understand whether the patient is taking these drugs for a long term. And usually for the NSAIDs, their definition is 3 per day for 3 months. For, of course, aspirin is usually chronic use. We should look in these patients for any symptoms of anemia, or any overbleeding, past history of hematemesis, or black colored stools. We must question them for weight loss and diarrhea, which may be a manifestation of enteropathy. And then perforation would obviously be clinically evident. Some patients may have diaphragm disease and present with partial small bowel obstruction, recurrent abdominal pain, and occasionally episodes of obstruction. Now, it is important that the patients who are at an increased risk, and this could be related to high dose of aspirin, concomitant use of other drugs like anticoagulants, steroids, or NSAIDs, or patient-related like H. pylori infection, history of past history of ulcer or bleeding, or elderly, and those with multiple comorbidities. These are patients who are at risk, and one must evaluate the risk of GI bleeding in these patients. Obviously, we could use symptoms like pain, dyspepsia, but then, as I have already stressed, that these are not really helpful in all of the patients, and even serious complications can happen without antecedent symptoms. Now, lab tests, most of the lab tests are non-specific. You could find some amount of microcytic anemia. If there's an enteropathy, there may be hypoalbuminemia or hypoproteinemia. And then again, positive occult blood, you can use that, but not when, the patient is on aspirin or multiple antiplatelets, because many of them have a normal endoscopy even when there is a positive stool upon blood. So not really a test which should be routinely used. So it's a very non-specific test, and the gold standard, of course, is endoscopy. And on endoscopy, you could find various findings. In patients where you suspect small bowel obstruction, one can proceed with a barium and CT, but this is a clinically, less common situation. More common, you end up doing endoscopies. You may find these kind of, let's say, erosions or superficial ulcers, then deep ulcers in the antrum, and then again you can have changes of enteropathy. These are erosions, these are superficial ulcers, and this is a bleeding ulcer in the duodenum, another bleeding ulcer. And these are the manifestations one could find in an upper GI endoscopy. And you might need to to get a capsule endoscopy done, or do a capsule endoscopy if there's a occult bleeding and you do not find a source on upper GI endoscopy or a colonoscopy, and then there could be presence of fatigue erosions or reddish folds, and then there could be superficial ulcers, which can be noted in, again, with aspirin use. And with capsule endoscopy, sometimes you can pick up these diaphragm-like lesions, again associated with NSAIDs, including aspirin. And enteroscopy can be helpful in these patients, can help in therapeutic treatment of GI bleeding. And earlier it was double balloon, but now increasingly there is a motorized spiral also there. There is spiral enteroscopy and single balloon which are available, and they have the advantage of allowing histologic assessment and providing a therapeutic access to these lesions. So now coming to the strategies to minimize, I would say, the risk of bleeding. So the most important, I think, is optimizing the duration of therapy. So if we come to primary prevention, the current evidence really doesn't support the use of low-dose aspirin for primary prevention. It may be appropriate to discontinue if it has already been started, if the underlying cardiac risk is low, that is 10% risk is less than 10-year risk is less than 10%. So low-dose aspirin is usually not recommended, but may be considered in a patient where the age is appropriate for 40 to 70, there's a high burden of cardiovascular risk, the bleeding risk is low, and the patient is aware that the expected benefit is modest. At that stage, that's probably the only situation you might still go ahead with the primary prevention. Now, coming to the secondary prevention for coronary artery disease, in patients with stable heart disease who do not have a history of infarction or a recent PCI or a CABG, the dual antiplatelet may not have benefit. For PCI in such patients with a stable heart disease, for bare metal stent, dual antiplatelet for at least 1 month, for a drug-eluting stent for at least 6 months. And for CABG, it may be reasonable to give for 12 months. Again, this is a 2B recommendation. Now, if a recent MI is there, this is the situation, irrespective of the therapeutic approach, whether you've used a thrombolysis or it's only a medical therapy or a patient has undergone PCI or a bypass, usually a dual antiplatelet is recommended for 12 months. And especially in the setting of a PCI with a drug-eluting stent, usually it is not recommended to stop these drugs. And of course, after 12 months, it is suggested that it may be reasonable to continue the dual antiplatelet. But again, if there is a high risk of bleeding, probably you could shift to a single antiplatelet. Now, these are just a summary again of the same recommendations, a slight difference between the US and the European guidelines. And this difference is primarily for the bare metal stent, where the European guidelines recommend a longer dual antiplatelet for around 6 months as compared to the American guidelines, which are okay even with a 1 month therapy in a stable coronary artery disease. For the acute coronary syndrome, again, you can see that there are no differences between the recommendations. Now, coming to the transient ischemic stroke, the dual antiplatelet is not recommended for long-term use and only for 10 to 21 days, after which a single antiplatelet can continue. And if there are cardiac risk factors, there may be a need to switch to anticoagulation. Now, you can see here that there were fewer non-fatal recurrent strokes and a better quality of life with a dual antiplatelet for a short duration, but it could increase the risk of bleeding. So this is the summary. I think I've already explained this, that primary prevention is usually out. For secondary prevention, the time must be appropriately adhered to, especially for the dual antiplatelet, which increases the risk of bleeding. And if the patients are at high risk of GI bleeding, one could, after completion of the appropriate duration of therapy, one could shift to a single agent. So now coming to the use of prostaglandin analogs, and we're going to talk about some of the evidence here. So Misoprostol is the drug, which is a prostaglandin E analog, synthetic, which is deesterified to misoprostol acid and is known to prevent NSAID ulcers. It may also reduce life-threatening ulcer complications. And if you can see, this is a trial where PPIs were compared with misoprostol for patients who were long-term NSAID users and a past history of gastric ulcers. You can see that randomized to placebo, misoprostol 200 microgram 4 times a day and 2 doses of the lansoprazole, you can see that the ulcers were much higher in the patients who were on placebo and the lowest in misoprostol and low in the 2 PPI groups. Now, the efficacy of misoprostol was similar to PPIs, and the side effects were also counted, because misoprostol can cause diarrhea, and therefore some of the patients will have to stop this drug. Now, this was a subgroup analysis of the same trial where the patients who were on aspirin also, so both NSAID and aspirin, only 70 patients, and you can see that here with the placebo, the ulcers at 12 weeks were 65%. So one of these drugs must be used, and you can see that co-therapy with either misoprostol or one of the PPI doses reduce the risk of ulcer development in the subgroup where low-dose aspirin will also be used. Now, again, this was a 34-subject study. Non-smoker volunteers were advised to take aspirin for 300 milligrams per day for 28 days, and you can see a group being given misoprostol and the being given placebo. At the baseline, the number of patients with erosions and petechiae were similar, but with time, you can see that the number of patients with erosions and petechiae were smaller in the misoprostol group. So it protects against development of ulcers, even when used at a low dose in patients who are being prescribed low dose aspirin. Interestingly, misoprostol also heals the small bowel ulcers. So this was 84 patients who were on aspirin and had a small bowel bleeding, but there was a need to continue aspirin. So they were randomized to placebo or misoprostol, and you can see that the complete healing was much more in the patients who were on misoprostol, and they had the lower number of erosions and ulcers also, and a greater increase in the hemoglobin. Now, there is also some data that if PPIs are used in the setting of NSAID-induced small bowel ulcers, then they may actually increase the development of small bowel lesions with NSAIDs. So in that situation, misoprostol probably scores over the PPIs, and one must consider this drug in that particular setting. So this drug is effective in prevention and treatment of NSAID or aspirin-related ulcers. They have significant adverse effects, and therefore, in a substantial number of patients, they may be need to discontinue the drug, and they're not usually preferred over PPI except in the setting of small bowel lesions. Now, coming to the role of proton pump inhibitors, and you can see that this was the OBERON trial, large trial, more than 2,000 patients who were H. pylori negative, were on low-dose aspirin for various, and they had risk factors for upper GI bleed like a peptic ulcer disease in the past, or elderly or upper GI symptoms of more than 5 erosion and endoscopy. They were randomized to the placebo, esomeprazole for 20 or 40 milligram, and you can clearly see the benefit of using PPIs, whatever the dose, the risk, the formation of ulcers was much less than the placebo. And in fact, in a secondary analysis, and another paper based on the secondary analysis, it was shown that not just the ulcers, but also the upper GI symptoms, they were much less in the patients who received PPIs. Now, another trial was the COGENT trial, where dual antiplatelet therapy was, the question was whether PPIs were beneficial in that. And again, a large study, more than 3,500 patients who had an indication for dual antiplatelet therapy were randomized to either receive omeprazole or placebo, which was added to aspirin and clopidogrel, which is being given to both the groups. And you can see, very important study, that the GI adverse event rate, as expected, was lower in the patients with omeprazole. But more importantly, the cardiovascular event rate was not higher. So there was always this concern about an interaction between clopidogrel and omeprazole, and that omeprazole may reduce the efficacy of clopidogrel, resulting in a higher cardiovascular event rate or mortality. But this did not come through in this particular trial. And therefore, the important message is that even without increasing any cardiovascular events or affecting the cardiovascular outcomes, the use of PPIs actually resulted in lower GI bleeding rates. And again, in another paper, it was shown that pain and non-pain scores were lower in the PPI. So the benefit is not just for prevention of ulcers, but also prevention of bleeding and the upper GI symptoms. Now, this was another study, 123 patients who had ulcer complications, so complicated ulcer disease, bleeding or bleeding, and then they were H. pylori positive. This was treated, the ulcers had healed, and after that there was a need to start aspirin. And then they were randomized to PPIs or placebo, and you can see that the recurrent complications were more in the placebo group than the lansoprazole group. And you can see that amongst those who had recurrence, a large majority had either a high Helicobacter pylori recurrence or had taken non-steroidal antibiotics. So now coming to the another strategy, that if patients are on aspirin, you could shift to clopidogrel. rather than add esomeprazole. So this was a study, 320 Helicobacter pylori negative patients with ulcers who had bleeding and were on aspirin. And even after their ulcer healing was documented, they were put on either Clopidogrel or continued on aspirin, and esomeprazole was added. And you can see that adding PPI was beneficial rather than shifting to Clopidogrel, and the cumulative risk of bleeding was much lower in those where PPI was added. So the better strategy is to add PPI rather than shift. So our H2 receptor block is acceptable. Now there are a lot of concerns about long-term PPI use. So people are interested in H2 receptor antagonists, and you can see that they may be acceptable in a low risk situation, but the bleeding risk is reduced much less by H2 receptor antagonists. And one must avoid cimetidine because of the significant interactions, and famotidine may be the drug which has less risk of interactions. Now we come to H. pylori eradication, and coming to the ulcers. So this was a meta-analysis which pooled the patients who developed ulcers on low-dose aspirin, and you can see that the patients who were H. pylori positive had a higher pooled odds of developing ulcer. So this means that Helicobacter pylori increased the risk of ulcers in patients who put on low-dose aspirin. So this was another study, a prospective observational study, patients who were on low-dose aspirin. And if there was a bleeding ulcer, then H. pylori was positive and it was eradicated, and ASA was started after ulcer healing. The other group was patients who had bleeding but H. pylori negative. Again, the ASA was started after ulcer healing. And then there were average risk patient, no ulcers. So no ulcers, new aspirin users, that is the one group. The other was bleeding ulcer, the ulcer healed but H. pylori negative, the aspirin was started. And then these were the patients where there was Helicobacter pylori, which was eradicated. So this is the intervention, eradication of H. pylori. And you can see that the recurrent bleeding was much less when compared to the patients who were H. pylori negative when the eradication for H. pylori had been done. And the risk actually was similar to the usual risk patient. So H. pylori eradication may reduce the risk of bleeding, recurrence of bleeding in patients who are on low-dose aspirin. Again, another trial, 400 patients with upper GI bleed, Helicobacter pylori positive. The ulcers were healed with PPI, and they needed to be continued on aspirin or naproxen. They were shifted, they needed aspirin or NSAID, and they were shifted to aspirin or naproxen. And you can see here that one of the groups which received PPIs, the other group received just the eradication, not the PPI after that. So initially eradication was given, here the PPI was given, and in the aspirin, the low-dose aspirin group, the recurrent bleed was not different. So if there is H. pylori positivity, the eradication is as good as a long-term PPI. But for the naproxen group, you can see the bleeding was more in the patients who had eradication, and this is the group where you need to give continuous PPI even after the initial treatment of the ulcer. So how do you manage the bleeding risk? So there is a need for antiplatelet therapy. You assess for GI risk. Is there a past history of ulcer complication or ulcer disease? If it is so, please test for H. pylori. In fact, the ACG guideline actually suggests that you test everybody who's on low-dose aspirin for H. pylori. So that's a slightly different strategy, but this particular strategy suggests that for those who have ulcer complication or ulcer disease, you test for H. pylori and treat it and eradicate it. For other patients who have a history of anticoagulant use or there is a need for chronic NSAID or steroids, you should consider PPI. Dual antiplatelet, definitely give PPI. If this is not present, but still there are risk factors like elderly or GI symptoms, one may still consider the use of PPI. So how do you test for H. pylori? So you have a stool antigen test, which is now available widely. But if you're doing an endoscopy, then endoscopic biopsies could be helpful, or a hydrogen blood test if available. But you need to stop antibiotics of bismuth for at least 4 weeks prior to testing, and the PPI should be withheld for at least 7 days prior to these tests. So finally, we come to the summary of what we have all discussed till now, and I'll briefly go over the guidelines, the statements in the guidelines which are available. So this is the ACG AHA combined guideline. suggests that low dose ASA associated with low dose aspirin is associated with increased risk of upper GI bleed. There's no difference between enteric or a non-coated preparation. The high risk of adverse events, if it is present, one should consider gastroprotection. The risk of upper GI bleed increases with the dose of aspirin. And in a chronic phase of therapy, doses of more than 81 should not be routinely prescribed because they are associated with an increased risk of bleeding. The decision for discontinuation of aspirin in setting of acute ulcer bleeding is to be individualized based on GI and cardiac risks, and the gastroenterologist and cardiologist must act in cohesion in such situations. Now, for the ACG guideline, clopidogrel reduces major cardiovascular events compared to placebo or aspirin, and the dual antiplatelet is better than both of these used singly. But it is not long-term recommended in the ischemic stroke patients because of the risk of bleeding. So it is recommended only in the setting of the ischemic heart disease. Now, this is a suggestion from the ACG Helicobacter pylori guideline that in patients who are taking long-term low-dose aspirin, testing for H. pylori infection could be considered to reduce the risk of ulcer bleeding. And those who test positive should be offered eradication therapy. This is a conditional recommendation on moderate quality of evidence. And then the guidelines on thienopyridines suggest that a combined use of dual antiplatelet increases the risk of bleeding, and those who are at a high risk of bleeding are the patients who have previous GI bleed, advanced age, concurrent use of other drugs, Helicobacter pylori infection, and the risk of bleeding is dependent on a number of risk factors. And it is better to use PPI or H2 receptor antagonists in these patients to reduce the risk of GI bleed. PPIs are better than H2 receptor antagonists. In a patient who has a previous upper GI bleed or multiple risk factors, PPI must be considered or used. And if there's a lower risk, you may avoid PPI or give a H2 receptor antagonist. Now, there are questions about the interaction between omeprazole and clopidogrel, but as of today, there is no evidence of a clinically important interaction between these. And the role of pharmacogenomic testing or platelet function testing as of today is unclear. So, if we were to conclude that antiplatelet use is important in many clinical conditions, and the use is likely to rise with a rise in the coronary artery or the cerebrovascular diseases. Now, the problem with these drugs is that though they save the heart, they bleed the gut, and therefore there is need to stratify the risk of GI bleed or the GI adverse events, and accordingly make changes to therapy. So the appropriate dosage and duration of the dual antiplatelet or the platelet therapy has to be recommended, and it has to be used for the appropriate time. In patients who have H. pylori, eradication must be done. There is a role of PPI in preventing the complications in high-risk patients and in patients who have certain risk factors for GI bleeding. And misoprostol is not usually preferred over PPI, except probably in a situation where there's a small bowel injury. Thank you for your kind attention.
Thank you, Dr. Vishal. It has been really, you covered everything which is required for a point of discussion. I just thought of raising, after looking at the question bank, what exactly we mean by low dose versus preferred dose versus high dose.
I think I touched upon that aspect. So low dose is usually anything less than 325 milligrams. The idea is that that's the dose where there is a selective, one would say, antiplatelet action. But that's not the real truth actually, because the GI side effects also start happening at doses, in fact, as low as 30 milligrams. So the selectivity is for the therapeutic action, not for the I would say the gastric injury. So low dose is for the antiplatelet action for the cardiovascular diseases. The high dose, of course, is the antipyretic and the anti-inflammatory dose, which is at the higher doses.
In the market, we have 75 milligrams and 150 milligrams. Now, I come with, say, an episode of MI or an episode of TIA. What would be your prescription to me, 75 or 150?
So this is again, in such situations, you need a quick action. So what is actually seen is that with the low dose, the action takes time. The antiplatelet action takes time. So in a MI, certainly a non-entry coated 300 milligram may be a preferable dose. Same, I think, for the stroke. Again, you need a dual anti-quick action you need. So in an acute setting, it is always better. You want an action, you give a higher dose. For the chronic thing, a stable angina or a long-term therapy, a lower dose is still preferable.
There was some discussion about H. pylori, aspirin, ulcer formation, GI bleeding and all. I'll put 2 or 3 questions for those people whoever are listening. Do I need to test and treat or treat and test? How do you look at that?
So
for H. pylori.
For H. pylori, I think one thing is very clear, that if you have H. pylori, you must eradicate it. But the question is, which patient should be taken up for this particular testing? Now, if you look at the ACG guideline, they clearly recommend that anybody on a low dose aspirin should also be tested. So virtually they are recommending a test and treat strategy. I would agree that in areas where the prevalence is very, very high, one could treat. But then I think this has probably nothing to do with the cardiac part, more to do with the prevalence of the H. pylori. Here we usually use a test and treat strategy.
Yeah. Now, most of the cardiologists, they start simultaneously, dual antiplatelets plus PPI as a, protocol. And we all tend to do not disturb actually. When they come to you with some problem, we do not disturb. Now, what is our take to the cardiologist? Because tomorrow, if this is made into follow-up, do you advise cardiologists to check some list saying that here is a smoker, here is a 70 years, and here has a history of peptic ulcer disease, and you be careful when you are doing DAPT? What would be the take?
So if there is a clear indication, sir, of a DAPT, a dual antiplatelet, most of the experts recommend actually giving PPI around. Now, that is the reason I think that all the prescriptions where we see both Clopidogrel and aspirin, the PPIs have already been prescribed. But I think the more important question is to really assess whether a dual antiplatelet is needed or not. Especially if you have a high risk of GI bleed or risk factors for GI bleed. I think that's the situation where one should take into consideration whether there is indeed a need for a dual antiplatelet. And apart from certain clinical situations and a certain period of time, which I touched upon, I don't think there is a blanket need to give a dual antiplatelet.
There was a small interesting observation which we made when we presented some data on upper GI bleed in tertiary level. Because these patients, when they walk in, majority of them are cardiac patients, and they apparently stopped their PPI and continuing DAPT, and they blood. When you go back, probably you could check some of your records, and those people who came with GI bleed had a history of coronary artery disease. When they stopped PPI, peculiarly they came with bleeding. I'm subjected to verification, but interesting observation. Now, this Misoprostol, I don't know why it never became popular, even though the data shows that it's as good or slightly better than PPI. The mechanism is very interesting.
Right. And I think the reason, in fact, even the expert consensus, I think the concern is always with this diarrhea, which happens in around, in fact, if you see, almost up to 40% patients may have some amount of diarrhea. And in fact, there was one study where they had used it in rheumatoid arthritis patients, and they saw that around 20% needed a discontinuation of this particular agent. I think people are overawed by the adverse effects. That's the reason it has not really gained attention. And the PPIs are, yes, easy to prescribe, easily available. So
I think I should talk to the TPC team, because I couldn't find many more questions, because I put quite a good number of questions to Vishal. I mean, he did answer very well. And there was only one small, this is probably we need to discuss is, I was actually looking at a kind of intermittent aspirin rather than everyday aspirin, because whenever we say some patient is going for a procedure, say ERCP, we say stop it for 3 days or stop it for 5 days. That means the action of aspirin can stay as long as 7 days or so. So I was asking somebody, is there anything like bi-weekly aspirin so that, we reduce? That's a good future to look at.
So if we look at the recent ESG guidelines, for most of the procedures, including sphincterotomy and all, they don't recommend stopping aspirin if it's a single drug. Only for the high risk, ESD or something like ampulectomy or a large polyp or where EMR is needed, they suggest that you may stop. So, we are more cautious and we usually.
We take, because of multiple reasons, including legal, we say stop for minimum of 72 hours and ideally for 5-6 days, unless the procedure is an emergency and we take all the precautions. Does the TPC time comfortable and you want anything more to be done? Ritu from TPC?
Hello, yes, sir.
I think Vishal did a very good job. He actually covered the entire subject. And the important take-home message is aspirin is reasonably a safe drug. Aspirin is an indicated drug. It is actually called frenemy, that is a friend and enemy. It's called frenemy, and that's a word used, which I have learned very recently. And maybe there is another topic which I want Dr. Vishal to take up next time under your teamwork is aspirin as a prevention of malignancy. That would be a different topic altogether. I'm not. Maybe that could be the next topic, maybe in a couple of months or so, where Vishal could address. Then he'll have the entire data ready with him. Are you okay, TPC team, Ritu?
Yes, sir.
So can I wind up this and request?
Sure, sir.
Thank on everybody's behalf, whoever is present. Lovely topic made into a small capsule, and the entire data is covered. Thank you, Sharma, to really enjoy.